Welcome back to Inside the Well Space, where we bring you conversations that empower, educate, and inspire you to take charge of your health with clarity and confidence. I'm your host, Kathy O'Brien. Today's guest is someone whose work is changing not only the way we treat breast cancer, but how women experience life after it. Dr. Rache Simmons is a nationally and internationally renowned breast cancer surgeon at York-Presbyterian Weill Cornell Medical Center. She's a pioneer in minimally invasive and cosmetically advanced surgical care. She not only is a top doctor recognized by New York Magazine, U.S. News & World Report, and Castle Connolly, she's also a trailblazer in techniques that prioritize both the physical and emotional healing of her patients. From developing the skin and areola-sparing mastectomy to leading NIH research in cryoablation, freezing tumors without surgery, Dr. Simmons is at the forefront of a more compassionate, whole-person approach to cancer care. In this episode, we'll talk about what it means to preserve dignity through innovation, why collaboration across disciplines leads to better outcomes, and how we're entering a new era of breast cancer treatment, where healing and appearance are no longer either or. Let's step inside the well space with Dr. Rache Simmons. I'm honored that you're here with us because you have had such an extraordinary career of not only learning, teaching, sharing, pioneering, but also caring for and healing women, which is just, I bow to you as a breast cancer survivor. Thank you.
Pleasure.
Why don't we start with this, because we know that breast cancer is basically an epidemic these days. There's a lot to it. It's not sort of a one thing. So can we start by maybe setting the stage of what are the stats of what's happening with breast cancer today?
Sure. So breast cancer is really common.
Yeah.
In this country, 1 in 8 women in their lifetime will develop breast cancer. Yeah. It is by far the most common cancer for women. And so it is very common, but the good thing is we know a lot about it because it is so common, and there are many ways that patients can be treated and do well after a diagnosis of breast cancer.
What sort of like is said now is, and what we are learning is that really heart health and heart disease is the thing that's going to kill women, not cancer, although we are singularly really focused on breast cancer these days because it is so common. I mean, the 1 in 8 stat's pretty intense. Are you seeing it in younger people now too?
We are, Kathy. We don't really understand why, and that's the honest answer.
Yeah.
But our patient population is drifting toward younger women. And we'll talk about this probably at some point later in the conversation. But the problem is young women often aren't being screened.
Right.
So when we do find these cancers, they can be more advanced, which is particularly tragic for these young women.
It is, though, isn't it? Yeah. It's so awful. I remember when I was just sort of anecdotally, when I was I was a new mom and I was older when I had my kids, and I had a friend who had had a double mastectomy in our mid-30s, I want to say. She had already had a double mastectomy, I think probably hysterectomy, I don't know. But she was diagnosed with breast cancer from a sonogram, not a mammogram. And so she said to me at that point in time, you must always have a sonogram and a mammogram. So I know we'll get into that. It was kind of mind-boggling to me back then. That was 20 years ago, You mentioned two things that just, again, to sort of ground our discussion. There are two things you said. You said de-escalation and targeted therapy. What are those concepts?
Right. So de-escalation basically means that we're able to do less invasive treatment for breast cancer patients, whether that is surgical or from a chemotherapy medical standpoint or from a radiation standpoint. So we're able to do less and achieve equal or better results. One of the reasons we can do that is this targeted therapy. That allows us to do is not take every breast cancer patient as a one-size-fits-all. I mean, there really are so many tests we can do now on the tumor cells themselves that really tell us a lot about that cancer and how that cancer is going to behave with various treatments. We don't want to give someone a treatment that's going to get them side effects and no benefit. That doesn't make any sense. So if we can give someone a treatment that really is targeted to their particular cancer to achieve the maximum results with the minimum side effects.
Okay, can I just say I'm so glad we're talking about this right now because, again, since the stats are that many of us are going to have this situation, when you are diagnosed, your head is spinning and you don't know what questions to ask. You don't know even about targeted therapies or if it's right, if it's wrong, what path to go down. I personally believe in data and statistics when it comes to treatment. That would be my choice of how am I going to tackle my situation? What's the best results that I could possibly get?
there are a lot of data that are out there. That's
Yeah.
a good thing. The layperson can find a lot online. Now, that's good and bad because they don't often appreciate what online applies to them
Right.
versus someone else. So it's there, but I also caution patients that don't go down the rabbit hole. That I mean, here you go. You read something about metastatic breast cancer, and you have a stage 0 breast cancer.
Right.
Well, it's just not the same conversation,
same, right?
or the same treatment. So it's important to have information, but have appropriate information.
Yeah, you say that right, and like with my situation, I had to do a round of chemo, even though it was stage 1, no spread. I had an onco test, which is a great test, right? That's a new thing.
Test.
They didn't used to do it on stage 1 cancers, and my onco score warranted a round of chemo and radiation.
Right.
I was like, great, fine. But I tell you that only because like at the end of my chemo, they made me like cut the ribbon thing. When you're done with it, I just wanted to go home, but they were like, no, you got to cut the ribbon. So I did, and they made it all like happy,
Right.
whatever. And my friend, who was also going through treatment, said, I will never cut that ribbon. And it kind of broke my heart because what it said to me is that she had metastatic cancer, right?
Right.
Yeah.
Well, I mean, Oncotype is a great example of a targeted therapy because that's a relatively new test that allows us to take the tumor cells themselves and get a score.
Right.
And that score tells the medical oncologist if the patient is someone who would benefit from chemotherapy or not. And it used to be much more global. Any big cancer, any positive lymph node got chemotherapy.
Right.
And that's not true anymore. I mean, there's some of these patients who don't need chemotherapy and will do equally well without it.
Yeah.
And then there's some little tiny cancers that you think would be nothing,
Right.
but they've got a high score.
That's mine.
And those patients do benefit from chemotherapy.
That's exactly right. I was like, really? When I talked to my doctor, I was like, come on. And she's like, no, this is a good thing. I was like, all right, let's go. Let's do it.
Right.
And then you just do it.
Right.
Right. So one thing that you said too is about just obviously like early detection, right? That's the key for all of us.
So key.
Yeah.
So key.
Yeah. Yeah. Because breast cancer isn't going to kill you. That's what Holly said to me actually when I got diagnosed. She's like, you're going to get hit by a bus before you're going to die from this breast cancer.
Honestly, early detected breast cancer survival's in the high 90 percentiles.
Thank you.
So, and patients do very well.
Right.
And you're right. Women spend a lot of time worrying about dying from breast cancer. They're more likely to die of a heart attack or a stroke than they are of breast cancer if they find it early.
We touched briefly on the side about the hormone replacements and estrogen and all that kind of stuff. But with breast cancers, oftentimes women are put on estrogen suppressants. And that, because if you have an estrogen positive breast cancer, the thought is, we want to suppress the breast cancer recurrence. But without the estrogen, you're hurting the rest of your body.
Right. Well, everything in medicine should be a balance of risk and benefits. So again, there's not, I think, a blanket overall absolute. Everybody has to have these anti-estrogens.
Yeah.
I think they do benefit some patients, and I think they're a very good drug.
Yeah.
And they're also there's several of them. So it's interesting that they all have basically the same end result as far as being an anti-estrogen on the body.
Okay.
But the different ones have different pathways of how they get there. And it's often the pathways that really cause the side effects.
Interesting.
So if you have a patient who didn't tolerate one because it just made her feel miserable,
Right.
she might do really well with another one. And that's the oncology world, the medical oncology world.
Right.
But that really is, it's again, a risk and a benefit ratio and finding the right mix for the patient.
Yeah. And that's exactly what it is too. And that's what we're doing here. Like this is what we're learning about. And I keep, the most important thing is to understand your own self and your own symptoms and to communicate with your doctor. This makes me feel bad. This isn't, this, I can't sleep, whatever it is. I can't, I have brain fog. Can't sleep. It's making me nauseous. Who knows what, but you have to, right? All of the above. And that there are options. It's not one thing. That's really important to remember because the aftercare for cancer is just as, relevant and important and longer lasting than the actual physical treatment is, right?
Oh, right. And the aftercare could be decades, many decades for patients.
Exactly.
Right.
Yes. And okay, so going back to sort of the early detection, exams and physicals, self-exams, and imaging, you mentioned imaging.
Right.
Can we walk through the different imaging options and at what age and why you should start them or do them?
Sure. Of course. So there has been still a lot of controversy as when to start doing mammograms.
Yeah.
And some people say in your 40s, some people say in your 50s. I'm a true believer it's starting at age 40
Okay.
for the average woman.
Okay.
And the reason I say that is about 25% of our breast cancer patients that we see at my hospital are between the ages of 40 and 50.
Isn't that crazy?
So if you don't get one till you're 50, you're denying 25% of those patients the opportunity for an early diagnosis and a
right.
cure.
And by the time they get to you, they're like, it's stage 4
Right.
or whatever.
So that makes no sense to me. So I've always said age 40 mammograms every
Done.
year. And the every other year is also, I think, doesn't make any sense.
Makes
because-
no sense.
It makes no sense.
I mean, ridiculous.
Because you're just inviting these tumors to grow.
Right.
So anyway, so once a year
Okay.
at the age of 40 for the
Done.
average person.
Yep.
Now, there are some people we would get them earlier. But the problem is mammograms in young women
Yeah.
are not as effective. And the reason is because younger women tend to have denser breast tissue.
Got it.
Mammograms are looking at changes in density. So the way I describe it is if you have something that's very dense in a very dense breast, you just can't see it.
Right.
It's like seeing a polar bear in a snowstorm. You can't see it. Whereas we get older, our breast tissue changes. And for most women, the breast tissue becomes much more fatty, much more clear.
Everything gets more fatty.
That's just the reality. But for your breast, it's a good thing as far as detection of breast cancer. So mammograms are much more useful in older women. So that's the mammogram piece.
Got it.
Ultrasounds.
Makes sense. Yeah.
Love ultrasounds.
Right.
I believe in ultrasounds.
And that's a sonogram. Ultrasound
Correct.
is a sonogram.
Right, same thing.
Okay.
Two different words for the same
Yep.
thing. So it's a completely different technique. It's actually a sound wave that goes into the breast.
Wait, so this is why my friend who was young got diagnosed by a sonogram.
Exactly.
Fascinating. Okay.
It's,
sorry
and
to
it's
interrupt.
really
Keep going.
it's really good in dense breast tissue.
Yes.
So for younger women, I definitely think ultrasounds are very beneficial. If we're going to do screening, then I think it's good for young women.
Would you then suggest maybe even if you're in your 30s and you have BRCA or whatever, maybe you do a sonogram and not a mammogram?
Well, you'd probably do all the above
do it
because there
all.
are some things you can still see on a mammogram. So if you're that high a risk, you probably would do both those and an MRI. But that's a special population of patients.
Gotcha.
So for the average person, mammograms at age 40, if the breast tissue is dense, which it probably is in your 40s,
right.
then I say add the ultrasound there. And every day I see cancers diagnosed by ultrasound not seen on mammogram. All the time we see
Can I tell you, is this normal now that insurance will cover it? Because when I was doing it 20 years ago, I insisted because of my friend, and doctors would poo-poo it. Oh, you don't need it. You don't need that. And I'd say, I don't care. I want it, And
No,
so
it is. It is covered by insurance.
Okay, good.
Now, and there's not really a cutoff. There's not an age cutoff that I would say stop the ultrasound.
Good.
It's a breast density cutoff.
Yeah.
So I have patients who are in their 70s that have dense breast tissue.
Oh.
They should get an ultrasound.
Right.
I have patients in their 50s that have just a window pane mammogram. They don't need an ultrasound.
Okay.
So it does often correlate with age.
Yeah.
But it's really about breast
It's
density.
individual again.
It is.
As we're talking about the individualness of all of this, it's
Right.
you have to know your body.
Right.
Right? You have to know. And then you mentioned MRIs. So what's that all about?
Right. So MRIs are a completely different test. And we don't really screen with MRIs unless somebody's really high risk of breast cancer. So somebody who, for example, that is a BRCA positive patient.
Yeah.
We know they're very, very high risk. Then it might make sense to get an MRI screening for them. Where I use MRIs predominantly is when I have a patient that has a diagnosis of breast cancer. And we're trying to decide, is she a good candidate for a lumpectomy
Right.
or not?
Right.
And so the MRIs are our most thorough test. And about 20% of the time, I'll see more on the MRI that's meaningful,
Right.
that changes her management. Now, I'll see that it's going to be a bigger lumpectomy. Well, now it's going to be a mastectomy because we see cancer all over the breast.
Oh my gosh.
Or we see cancer in the opposite breast all the time.
Really?
And that changes management, clearly.
And that didn't show up in the mammogram.
Correct.
Oh my gosh.
Yeah. So I like MRIs
That
for the
makes me
appropriate
nervous.
patients.
Although no, I've gotten a mammogram already. I mean, I've gotten an MRI already, but the sequencing was different in my world. We didn't do the MRI initially. I mean,
Right. I believe in MRIs. I really do. I think they're great in making surgical decisions
yes.
about lumpectomy or not. Because if you don't do it and then you go in thinking you're going to have a lumpectomy,
Right.
and you get positive margins,
Right.
and then you go back in,
Then you gotta do it again,
or
right?
worst case scenario, you don't see anything else because it was cancer elsewhere in the breast that you didn't find,
Right.
and then it's going to bubble up and become a problem in the
Bigger.
future.
This is why there's recurrence.
Well, that's one of the reasons there's recurrence, but. People say, "Oh, well, you end up with more mastectomies." Well, yeah, you probably do.
Yeah.
That's because they needed them.
I know. Exactly.
Yes.
Exactly. You said something to me the other day, which has been sitting with me. I have a couple of friends, as we all do, who have had breast cancer, and they just opted right away for a mastectomy. They were like, let's go. I don't want to mess around with it at all. And when I was being diagnosed, and I saw two different doctors who said, you don't need a mastectomy. You need a lumpectomy because your cancer's small and blah, blah. And there's stats that say it's equal results. But I'm not so sure that that's the case. Is that the case?
Well, it depends.
Right.
I mean, certainly there are some patients who just clearly need a mastectomy.
Yeah.
There's just too much disease to be practical for a lumpectomy.
Right.
Off the beginning, they need a mastectomy.
Yep.
Now, there are other patients that don't need a mastectomy, but they might choose to have a mastectomy because they either don't want to have the radiation because it's a partner, lumpectomy plus radiation.
I know.
Or they're just worried about breast cancer.
Thank you.
And they don't want to worry about it the rest of their life.
Exactly.
Or they're very, very high risk because of family history or some other reason. And then, of course, there's always the option of a double mastectomy.
Yep. I would have done that if I would do both and get new boobs.
Well, and it's always an option. And I have a lot of patients who do make that decision.
Yeah.
And again, they would make the decision because they're either worried about breast cancer.
Yep.
They don't want to worry about breast cancer.
No.
For our younger patients, the chance of an opposite side breast cancer is about 0.5% per year. Now, that's not so much when you're 60. That's a lot when you're 35.
Well, yeah, right.
That really adds up.
Yeah. Well, even when you're 60, I don't want that. I don't want that.
Right.
But
and then the other reason patients might choose to have a double mastectomy is cosmetic symmetry.
Correct.
So what I tell them is, talk to the plastic surgeon and ask them, when you do one side with a mastectomy and you leave your natural breast, how symmetrical or asymmetrical will you be with the reconstruction?
Well,
and that can be a deciding factor sometimes too. Is they just say, it's going to really not look good, and I'd rather just do both.
Yeah,
that is a decision. Now, back to your original question, as far as outcome, survival is the same with a mastectomy versus a lumpectomy plus radiation.
Okay.
What's not the same is either a recurrence or an occurrence, and they're different.
Okay.
A recurrence is having that breast cancer come back.
Got it.
With a mastectomy, it's low. Nothing is 100% in medicine. I mean, that's just the reality.
Right.
But it's really low.
Okay.
It's 1% or less with a mastectomy.
Got it.
Occurrence is a different question. The occurrence is a chance of a completely new independent breast cancer of the same breast or the other breast.
Right.
Well, if you haven't got breasts, that's not going to happen.
Right.
Again, very, very, very unlikely.
Right.
So you go from somewhere of maybe a 5-10% chance of a recurrence, occurrence depending upon family history, age.
Right.
And then compared to basically less than 1% for both.
Right.
And that's why a lot of patients say,
it's not even a question in my mind.
And the other thing now is they just look so darn good the way we do it. So it used to be a big decision, and now make the incision down and the crease of the breast where your underwire bra wire would sit.
Right.
That incision heals beautifully. It's a natural wrinkle we all have anyway. Right. And then with the reconstruction, you don't even see that incision.
I know.
And through that incision, I remove all the breast tissue.
Right.
I save all the skin. I save the nipple and the areola.
Well, you're good like that. That's your whole thing is this phenomenal
This is
cosmetic.
something that I've done for decades.
You're like a pioneer with that, right?
And I love offering it to patients. They're so happy with it.
Yep.
And then they have the reconstruction. They look fantastic. Quite honestly, some look better.
I believe it because things sag.
They look better. And I will also say that I have never had a patient regret the decision for a double mastectomy.
Yeah, I know.
I've had patients regret not doing it because sure enough, 5 years later, you pop up with a new breast
It's on my mind. I got to tell you.
And then they say, well, what do I do now? Because now I've had the radiation, which we can work around it, but it sometimes does compromise the ultimate cosmetic results of the reconstruction. And then if you've had the belly fat reconstruction, well, you can't do it again. So then you're not going to match. So then there's
explain the belly fat thing because I like this.
So there are two main ways to have breast reconstruction. One is implant reconstruction.
Right.
One is belly fat.
Okay.
The belly fat basically is a tummy tuck.
Yes.
But instead of discarding it, they just move it up and make 1 or 2 new breasts from it.
Why
it's
would
your own
you want
fat,
this, girls?
Well, I mean, there's some patients that aren't a good candidate. If you're too thin or if you've had various surgeries that doesn't allow good blood supply to the fat. So there are reasons where it might not be the right decision for some patients. The implants can look great too.
Right.
So it really just depends upon what's better for the patients. And what I tell patients is, look, I do my surgery exactly the same.
Yeah.
Whichever kind of reconstruction you have. So I had that conversation with the plastic surgeon, and whatever you guys decide is fine with me.
Okay.
That's what we're going to do.
That's so good. Let's just stick on that for just a second because the preserving the skin and saving the nipple, you were kind of a pioneer of that, weren't you?
Yeah, I was. It's a long time ago. Yeah, I was. And it just made sense.
Yeah.
Because we kept saying, well, it's not a breast cancer is not generally a disease of the skin.
Yeah.
It's a disease of the breast.
Yeah.
So why are we taking all the skin?
Yeah.
And the answer was always, well, because we've always done it that way. I was like, well, that's not a good answer.
No.
That's not a good
Not
answer.
an answer.
So what if we did something a little bit different that might be, just as good? So then we started looking at the idea, saving the areola, saying, well, maybe the ductal tissue in the nipple, it's not as safe. So we did that for a while, and we found that, sure enough, patients did just as fine.
Yeah.
And then we said, well, what if we save the nipple? And we did that, and patients did just as fine. And so what I always tell patients is that I take that little bit of tissue kind of right behind inside the nipple itself, and I send that off separately to pathology.
Okay.
If it happens to come back showing cancer, okay, we have to take the nipple.
Yeah.
But it rarely does.
Yeah.
And those patients really benefit cosmetically from having their own skin, their own nipple. They look great.
Yeah, they look great.
Yeah.
The 2 doctors that I had seen when I was trying to figure out in my haze of what to do with myself said that even if you because I was like, take them. I don't care about my hair. I care less about these. I care about my skin because that's hard to it gets pummeled. But, and they were like, no. Because when you get a mastectomy, it's impossible to get all the tissue, and that some of it can remain, and you can get breast cancer again. Is that what?
Well, that is true.
Okay,
it is true. But a well done nipple-sparing mastectomy, you're getting the vast, vast majority of the breast tissue.
Okay.
What I always tell patients is it is true.
There's always a chance.
That's why it's nothing in medicine 100%.
Right.
But done well, it's really, really a low risk. You're really close to zero.
Right.
Yeah.
Yeah. So someone like me, I could call you up and say, let's get rid of them right now. Even though I went through my treatment and I did all my thing. I could just be done and just right?
You could if you chose to. Yeah.
Okay. Well, keep your phone on. So, all right. So that's really great. Let's talk about the different therapies because there are a bunch of them. Chemo, endocrine, pre-mastectomy, blah, blah, right? All of it. Can you go through them all?
Right. So generally the 3 main categories are endocrine, anti-estrogen predominantly.
Right.
Or chemotherapy.
Yep.
And radiation.
Yep.
And they're really very different. So the endocrine and the chemotherapy treat the whole body. They also treat the breast as well, but the whole body. The radiation really only treats the area of the breast and the chest wall.
Yeah.
So radiation is typically a partner with the lumpectomy.
Yep.
We usually don't give radiation after mastectomy. Occasionally we do, but we don't usually do that because the breast has been removed.
It's gone.
Right.
Yeah.
So the other 2, the endocrine and the chemotherapy, are also different. The endocrine targets the receptors on the cancer cells, like the estrogen receptor.
Got it.
Chemotherapy targets sometimes another receptor on the cancer cell called HER2.
That's what
Right. Or it's given because there are no receptors. Triple negative breast cancer means there are not receptors for estrogen or HER2.
Got it.
And that would be chemotherapy as a appropriate treatment for them.
Right.
Now, when it comes to chemotherapy, we usually give it after surgery, but there's sometimes we give it before surgery. And the reasons we might do that, if somebody has a really big breast cancer or they have a lot of positive nodes in the axilla, if we give chemotherapy before surgery, we can often just melt that away.
Wow.
Definitely make it smaller and sometimes really melt it away. So that when I go in and do the surgery, there's no cancer left. So, which is amazing.
Yeah.
So that's, again, a targeted type of therapy. Whereas if we know that you have those receptors or lack of receptors, then we can recommend certain drugs that will work really, really well on your particular cancer.
Yeah.
Now, what would be really amazing, and it's coming, we're not there yet, but it's coming, is for those patients where we give them the chemotherapy ahead of time and it melts away on imaging.
Yeah.
And then I go in, there's nothing left on pathology. If we knew who those patients were ahead of time, we wouldn't do the surgery.
You wouldn't do it.
But we're not there yet.
Right.
We don't have anything that's reliable enough to be able to say, you're the lucky one where we don't have any cancer left. But it's coming.
Yeah.
It is coming. That's going to be something we're going to do in the future.
Gosh, that's mind-blowing to me that that's actually possible. That you can know that. And just, but then so it all disappears, but then who's to say it's not going to come back?
Well, you'd follow the patient carefully by whatever makes sense. And that's another conversation that we began. How do you follow a patient after a diagnosis of breast cancer and surgery and radiation or whatever's done for them? And, obviously one of them would be exams and one of them would be imaging.
Yeah.
But we'd spoken earlier about this whole idea of the liquid biopsy.
Wait, I love this, by the way. Tell us about that.
So liquid biopsy is a way that you draw a tube of blood.
Yeah.
And you run that blood and you look for either cancer cells
Yep.
or cancer DNA. They both work. It's just a different test. What could be so incredible about that would be you've got a patient, she's had breast cancer. Every breast cancer patient is worried is going to come back.
Yep.
If you could have this blood test once a year and it's clean, that's a really good assurance
Yes.
that your cancer has not come back.
Right.
Or if it does show something, then you can find it much earlier.
Yeah.
You'll be able to find it on just standard imaging.
How?
So-
What? Will it give you a sense of where it is in your body?
Well, it might or might not. And
Okay.
that's another question that's interesting about
Yeah.
this. So it would be a way to follow patients who have had a diagnosis of breast cancer and
Yep.
perhaps other cancers as well, but a way to have really, really early detection of a recurrence.
Yes.
Now, what is even more exciting about that would be, could this be a screening test?
Yes.
Could this be a test? You go every year to your doctor, you get a tube of blood,
Right.
and they run this, and they say, you're cancer-free. Or,
Right.
we see something.
We see something, we don't know where it is, but we're going to find it.
But you might not even need to know where it is
See,
because
that's
you're going to
the-
have so much information about that cell. And this is coming. It's not
Okay.
here right now.
Right.
But you're going to have so much information about that cancer cell
Right.
that it's going to tell you what drugs are going to
Oh.
kill that. And it honestly doesn't matter if it came from your ovary or your pancreas or your breast.
Right.
It's telling you that these are the drugs.
And it's the beginning bubblings of something that's going on, and the drugs. These are the drugs that can knock it out.
We're going to do that. And then we're going to
like an
follow you,
antibiotic.
not say by imaging, because it wouldn't be seen by imaging anyway, it's so
Right,
tiny.
right.
But we're going to follow it by serial blood tests.
I love it.
And as long as it's clean, you're good.
How often do you think? Is it 6 months, a year?
I don't know. This is in the future.
It's
So I
new.
don't know. I don't know.
I will tell you though. So last year, I'm like the years are now blending in my brain, but probably 6 months after I finished my treatment, I did a Grail test. Which is the cancer
Right,
panel
right.
test.
It's one of those, right.
It's one of them. Yep. I did that, and it came back clear. And then
Which feels really good.
it felt great. And then I did it again this year. And I'm going to, well, first of all, the price came down already by like $200 because
Right.
it's not covered by insurance yet.
It probably will be at some point.
I
in the
hope
future.
so. That's what Holly said. She said one of these days this will be the gold standard. It's not now, but I did it again when like my hips started hurting and my oncologist wanted me to get an MRI. I was like, oh, for God's sake. And so it's fine. Everything's fine. But I was like, okay, let's do another blood test and find out if there's anything percolating. And it was after our conversation that happened. I was like, yeah, I got to do this. So
It could be. That may be one of the ways that we give the patients the chemotherapy. The cancer melts away on imaging.
Right.
And maybe it's the blood test that would
Right.
say, is there cancer still present by these cells or not? And if not, maybe that's the way we don't treat them surgically. Again, this is in the future, but I think it's all very possible.
But it's the future and now almost too, because it at least gives you some sort of feeling of control. And it's much less invasive and
Right.
less scary
Right.
because I can go to my doctor and just say, I'm going to take this test and it's no big deal. And you know what I mean? And because going through the cancer stuff is scary. It's very scary. It's a scary thing. One thing I wanted to ask too is the lymph node testing when you're doing it all. We talked about, okay, there's lumpectomy plus radiation. There's a mastectomy with no radiation. There's chemo thrown in there for whenever. What is the whole lymph node testing and like why is that important?
Sure. So when breast cancer spreads, it typically goes to the lymph nodes in the armpit area first.
Yep.
So
I have a nice little scar to prove it.
So that has been historically the way that we test to see has the breast cancer spread. And if that's clean, then we assume the rest of the body's clean also.
Right.
If it's not clean, then more surgery might be indicated, more treatment might be indicated. So traditionally, historically, every patient that had breast cancer got all their lymph nodes taken out.
Right.
20 lymph nodes, 30 lymph nodes. And this again is the de-escalation. So then it went and probably
Because that had big problems. That caused big
it does
problems.
cause problems.
Like
It causes
lymphedema
swelling of the arm, exactly.
all that
Numbness,
That's
a lot of problems.
Yeah.
So that's not a great surgery. We
No.
don't do that. We rarely do that anymore. Probably, I don't know, 15, 20 years ago, there was a new way to do it that we were able to identify the lymph node called the sentinel lymph node.
Okay.
The one that was the most likely lymph node to have cancer cells in it, if any of them do.
Right.
And so that's done with a combination of some sort of a dye or
Yeah.
an isotope is injected into the skin of the breast.
Yep.
That is then taken up in the same way that a cancer cell would be if any
Yep.
had gone to the lymph nodes. And then we either visually or by a little probe are able to identify which node is the key or the sentinel node.
Yep.
Take that one out, have that one tested.
Yep.
So that's all great. And that's a much less surgery than we were doing before. We're taking all them out. So that's a very standard of care now for breast cancer patients. But now we're able to even say in a certain population of patients, this is data from big clinical trials, that if you're postmenopausal with a small breast cancer that is not an aggressive cell type, and you've had an ultrasound of the armpit that looks normal, we don't even take out lymph nodes.
You don't?
At all. Not even a sentinel node.
Wow.
Because the vast, vast majority are not going to have positive nodes.
Right.
And it just saves them another surgery. So again, this de-escalation of how we're treating patients.
God, that's so great.
It is great.
It is great. I know. And I'm thinking about, too, I'm just thinking about this whole liquid biopsy thing and thinking, too, that it's almost going to be like antibiotic treatment in the future. You know, you go in, you find this thing, you got these little bubblings, and you take maybe a chemo tablet or an estrogen. Who knows what?
Maybe.
It's something. It's anything. What about the whole idea of genetic predispositions and BRCA? How does that play into everything?
Sure. So BRCA is probably the most well-known genetic risk factor for breast cancer. And if someone is BRCA 1 or 2 positive, then you're at a really high risk of getting a breast cancer in your lifetime, probably 80-85%-ish. So it's high.
It's high.
You may also be at a high risk of ovarian cancer and other cancers as well.
Okay.
But many women, most women, if they know they're BRCA positive, do choose to have a double mastectomy. So we have a lot of patients that do that. And again, nothing in medicine is 100%, but you're getting really close to zero as far as getting breast cancer. So it's
wonderful.
It is. I mean, that is, for most women, curative to not get breast cancer.
Totally.
Right. Now, it's not just BRCA 1 and 2. There are other mutations as well. There's CHEK2, there's ATN, there's a whole list of other mutations that can also put you at a higher risk of getting breast cancer. And those women also might choose to have a double mastectomy or be followed much more closely. Right. One or the other.
Starting at what age?
Well, it depends on when they get tested. You know,
when should you get tested?
Well,
as a young woman, if you know it's in your family.
If it's in your family, then I recommend that people should at least be given the option of being tested. It's called cascade testing. To test your first-degree relatives for these same mutations. If you're being positive, then you have a choice. You can be followed really carefully. Or you have preventative surgery.
Right.
There would certainly be an age that'd be unreasonable to test someone. We're not going to test children. There's no reason to. There's no reason to.
No.
Because patients often say to me, well, should I test my teenage daughter? I'm like, no.
She's like still developing.
There's nothing you're going to do except worry about it. So there's no reason to test teenagers with genetic mutations for this.
Right.
Somewhere in their mid-20s or so would probably make sense to be tested.
That's fun.
Because then it's something you can make a reasonable decision what you want to do.
Right.
For the results.
Right.
So, genetic testing makes sense. We do it very often with our patients.
Yeah.
And what's interesting is even the ones that don't have family histories and have breast cancer, about 10% of those patients are positive.
What do you mean positive? BRCA?
With BRCA. And so what that's saying is their family obviously has it, but no one developed breast cancer because not everybody who's BRCA develops breast cancer. So you'll test these women and you'll find out they're positive, which is telling us that it's a mutation in their family from somewhere.
Yep, totally.
And there just haven't been a lot of breast cancer diagnosis in the family.
No breast cancer. And I'll tell you, and then there's my circumstance, which I had, obviously you get genetic screening after you get diagnosed because that helps determine the treatment that you're going to get, right? Mm-hmm. Nothing in my family, nothing in my genetic makeup, not a thing. Then there's that.
Well, the vast majority of women who get breast cancer don't have a family history. And that's something else people don't realize. And
Really?
Definitely the vast majority is not BRCA positive. That's a very, very small subset of breast cancer patients.
That's societal then, right? I mean, it's got to be societal.
People have this misconception.
Yeah.
Oh, I don't have a family history. I'm not getting breast cancer. I'm not going to get my mammograms. Well, that's
dumb. That's just like not smart.
That's just not smart.
No. You got to get your mammograms. Seriously.
Or ultrasounds.
Or ultrasounds,
or both.
or MRIs, or all of it.
Something.
Right. All the above that we just discussed. It's true. Something that was really cool that you talked about in sort of like newness in treatment too, along with this liquid thing that I'm obsessed with, is cryoablation.
Right.
Can you talk about that?
Sure. So cryoablation is dear to my heart because one of my areas of research from decades. What it basically is taking a probe, smaller than a pencil, little probe, and the tip of it gets really, really cold. So you use ultrasound to guide it into the breast. You numb the skin, tiny little incision, insert the probe, guide it by ultrasound to the middle of the cancer or tumor. and it gets really cold and ablates the cancer or tumor. Now, we used it initially on benign tumors, fibroadenomas, very common in young women,
Yep.
and it worked great.
Yep.
They melted away, and that was it. And then we started looking at it in breast cancers. And we did a series of trials looking at this, very thoughtfully and safely done. The first thing was we looked at it with doing the ablation and then resecting the cancer to see what happened.
Right.
Was it really killed? Was it not?
Right.
And we learned a lot from the first few trials.
Okay.
We learned that certain cancers lend themselves very well to ablation, certain cancers don't.
Right.
So that was useful. There are size limitations with the current technology of what we can do with the probes to freeze, and we want to get a border around it.
Yeah.
That's a safe border of a buffer between the cancer and the ablated edge zone.
Yep.
So we learned a lot about that. Next series of trials, there have been 2 at this point, 2 large trials. What we did was we ablated with the knowledge of who were good candidates for the treatment from the previous trials, and then we didn't resect it. We just left it, and we followed them. Okay. And these were very low-risk patients, the ones who were kind of the best of the best as far as we thought we could our really good results. And we did. We got great results from this. And we found that the recurrence rates were pretty much on par with what you would do if you did surgery.
Amazing.
And so I think, again, that's a wonderful technique.
Yep.
The limitation with it right now is the insurance company is considered to be experimental still.
Got it.
So we're having a hard time kind of getting it off the ground because there's not reimbursement for it. So outside of a clinical trial, it's just not covered by insurance.
Do we need more clinical trials to make it happen?
Or just get the insurance companies to agree to start paying for it. And honestly, I'm surprised that they wouldn't see it as attractive because it's so much less expensive than a surgical lumpectomy.
Seriously.
So and the patients are happy with it. Patients do well with it. So I don't quite understand what the limitation is in getting it approved by insurances. But we're not making a lot of progress.
I think lawsuits. They're worried about lawsuits. Who knows? I don't know. That's what I think. Okay.
That's another in the future thing I think will be really great.
Yeah, I think so too. Well, that's heartening, actually. It's really heartening because a lot of what we're talking about now, and I mean, we've talked about a lot, but a lot of it sort of says that things are getting better in terms of, look, we used to think that we'd get a cancer diagnosis and things were over. That's just not the truth now. Mm-hmm. Like you were saying, early diagnosis, we really
high 90s percentile of survival and doing well.
Okay, I feel so good about that. Yeah. The other thing that was really important that you mentioned, which I love, is you talked about the care team, the importance of having the care team and choosing your care team.
Yeah, it is. So for a woman who's diagnosed with breast cancer, you're going to call someplace to be seen. And what I think you should be looking for is to make sure it's a team approach, because it makes a really big difference. To make sure that the medical oncologists and the surgeons and the plastic surgeons and the pathologist and the radiologist and the radiation oncologist, that they're all talking together about you and about what's best for you as a group. So I think that's really important. And I think that the most breast centers have what's called a nurse navigator.
I love that.
Nurse navigator is a wonderful person because you make that phone call. And my patients say it feels like you're just falling in air and this person catches you in midair. It's like, okay, we've got you. We're going to take care of you. This is what we're going to do. This is the next step. This is the next step. And then they guide you through the whole process to make sure you don't get dropped anywhere.
Well, yeah.
And so I think that's really important. And part of that, years ago, I was part of this creation of this accreditation for breast centers.
Yeah.
It's called the National Accreditation Program for Breast Centers.
NAPBC.
Exactly.
I wrote down, and you did this.
I did. We helped create the standards of what would an ideal breast center include.
Yeah.
And so there's standards now. They get accredited, and you have to be reaccredited every few years.
Great.
And it then tells the public that this is a place that meets these standards of care. They have the group approach, they have the navigators, their results are what you would want to see.
Yeah.
Their accreditations for their radiologists and their surgeons and everything else, all what you would want. Because patients don't know to ask those questions.
No, how would you know?
They don't know is this a good place or it's not a good place for breast cancer care.
You don't know. When you get this diagnosis, you are spinning. Right. And this is really great to know. And how fabulous. Okay, ladies. NAPBC, when you're looking, it has to be that. It has to be an accredited place. Okay, believe it or not, we've been talking for quite a while now. And we're at the moment where we have to synthesize really and think, okay, here we've been talking about all of these wonderful things that are so important and helpful. If you were to tell our gals 3 things that she needs to think about when she's thinking about breast cancer and getting a particular diagnosis, what are those 3 things she should remember?
Well, I would say absolutely first and foremost is screening.
Yeah.
Yeah, I mean, just make sure, don't ignore the opportunity for an early cure and survival. So get your screening appropriate for your age and your risk. And then if you do find breast cancer, I would say go to an appropriate place where you'll get good care and do the care. I mean, where there's
the treatments.
The survival is so good,
right?
There's no reason to put your head in the sand.
I know.
Do the cure.
Do the cure.
Do it for cure.
Right. I think I told you this, that when I went back for a checkup with my doctor, I don't know, I was already in the middle of chemo. I had already met the radiologist that I was going to be working with, and she said, are you doing your treatment? And I looked at her like she had 10 heads. I was like, what do you mean, am I doing my treatment? Of course I'm doing my treatment. And she's like, no, Kathy, you'd be surprised. Some people just don't. I see them 6 months later, they haven't done their treatment and they've missed the window.
Yeah.
You've missed your window.
You've missed the window of opportunity.
You've missed the window, right? Yeah. So thank you. I mean, really, thank you so much. I'm really looking forward to you coming back and having a bigger conversation around everything that goes into, breast health and cancer and hormones, et cetera. So we're going to work on that with Dr. Creatura too. So we'll do that together. Thank you again.
You're welcome. It's a pleasure.
Thank you so much for listening to this episode of Inside the Well Space. Subscribe now on Apple Podcasts, Spotify, YouTube, or wherever you listen to your podcasts.